to broadcast. And it looks like it's automatically recording. Good, okay. Oh, this is the fun part where we get to see everybody coming in. Very fun. So hello everyone, we're opening up the room and we're going to be waiting until noon to start the presentation. So we've got a few minutes, but welcome. I'll also look out for Dr. Jeunemaitre and the attendee list.
Okay.
As that happens. Hello, Maggie. See some people I know and some people I don't. Welcome. I guess I should have the chat box open too. Well, that's neat. I didn't realize that Huva had an opportunity for you to write your own notes in the app while you're watching the presentation. Very neat. Oh, there's Xavier.
Oh, can you mean? Okay, great.
Promoting the panelist. Let's see. Hello.
Hello, hello. How are you?
Good. How are you?
Fine. Hi, Shaine.
Hi, Xavier. How are you?
Fine.
Hello. How are you?
End of vacation.
Yes.
Oh, we have 6 people right now joining us, so we've got a few minutes, so I'm sure we will have some more. I think there were over 100 that said that they were interested in coming to this one, so
Okay.
very exciting. And I know with all of the different time zones, you might have people watching it later in the recording, for sure. That's the great thing about this, is that they're able to do that. Really wonderful. Well, I can hear and see you just fine, Xavier. It's good lighting.
Joe, how long will the sessions be posted where people can access them?
I don't think we've come to a decision on that as yet. I'm sure they'll be posted for quite a while. You know, we're doing aortic dissection week, and after that, so I don't think we've decided, and I don't know that there's a specific time associated with the conference app. I'm not sure about that.
Great.
So, Kari, the idea is that you are displaying the videos and then we answer to the questions to the audience?
Yes, that's right. So
Okay.
we'll have, both of you have pre-recorded presentations. I will introduce you real quick. I'll let you say hello to everybody, and then we'll go right into the presentations. At that time, we'll all take our videos off and put ourselves on mute so that it doesn't interrupt the presentation. And then I'll hit play, and then after the presentations are over, you and Shaine will both go back on video, and I will answer. I will read you questions from the Q&A.
Okay. I was a little bit long in my presentation, so you did cut it? Some part
We left it, we did leave it the full amount. So I think we'll be about 47 to 50 minutes for presentation, and then
Perfect.
about 10 minutes at the end. If you guys want to stay an extra 10 minutes, maybe we can answer more questions, but it's really up to you.
Perfect.
And I know that if any questions aren't answered today, they will be able to submit them to our Help and
Yeah.
Resource Center.
Okay.
But we decided we didn't feel comfortable cutting the presentation, so we left it as is.
Okay.
Thank you. So welcome everybody. We're going to get started in a few minutes. Hello, Kathy. Hi, Fran. I'm seeing some people I know. Very cool. We have about 15 people now. And there is a chat box and the Whova app if anybody wants to tell us where they're joining in from. We are going to get started in a couple minutes. I feel like I need to have jokes prepared or something for the beginning of this when we're waiting.
There's a lot of new names there.
There is really a
Well, I
lot of
don't know.
names.
Mhm. Which is great. We want
Yeah,
to welcome everybody.
it's really great. For some reason, my chat only shows like 2 messages at a time.
Yeah, mine does the same. I don't know. We're up to 23 people so far, so that's great.
I see someone has raised their hand. If you have a, we can't do anything with the raised hand, but if you have a question, you can put it in the Q&A box, or you can just say hi in the chat box if you're just raising your hand to say hello. '27, Michael Weimer's on. Hello, Michael. And Deborah, I see Deborah Niaspaziani. Hopefully I said that right. Good to see you, Deborah. And we're up to 30. I love this part. I love seeing everybody join. Oh, Ashley Marish is on. Hello, Ashley. We'll get started in just a moment. All right, it's 12 o'clock. We're going to get started. Hello, everyone. I'm Katie Wright. I'm the director of the VEDS movement. If you don't know me yet, you will. And I love everybody, so welcome. It's really great to see you today, or at least see your names in our little attendee box. We're definitely thrilled to have you join us today for our very first International E3 Summit, which is powered by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. We would like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction. Before we begin with the presentations, we just want to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. I would like to give Dr. Shaine Morris and Dr. Xavier Jeunemaitre an opportunity to say hello. We're very grateful to have them today. So if you guys would like to say hello before we begin the presentations.
Hi, everyone. We're glad to be doing this on this forum. This is really exciting, and I'm happy you guys are here.
Hi, everyone. Also, I'm very pleased to join you from France and hope that we will have a very fruitful meeting.
Thank you both for joining us and preparing presentations. Today we're going to be hearing about the ABCs of VEDS, and they have both prepared presentations for you. So now we will be turning off our videos and playing the videos for you, and we will continue with a Q&A after these videos.
So, hello, I'm Xavier Jeunemaitre, working in Paris in the National Reference Center for Rare Vascular Diseases, especially VEDS. I'm also working in an INSERM unit for research on this particular disease, and at Université de Paris, which is a new university created this year, merging two universities in Paris. So I'm very happy to give you this summary on diagnosis and treatment on VEDS. Our reference center in Paris is mainly working with 13 other centers in France, as you can see on the left part of the slide, which are displayed around the country. And it's within a network which is called FAVA Multi, which is a network on all arterial disease and all vascular disease, not only VEDS, but other type of rare disease also. And this is funded by the Ministry of Research and Ministry of Health, which helps in terms of dotation funds for these different centers and the disease itself. So we are going to speak on vascular EDS, which is not a typical EDS syndrome. It's a syndrome which is caused by a defect in a particular gene which is called collagen type 3. And this defect causes a particular syndrome, and we are going to speak about that. It's relatively rare, inherited, autosomal dominant, that is when a parent has this defect in collagen type 3, it can transmit to his son or daughter by 50% of risk. You have a lot of different variants, and we'll see that in terms of genetics. And you have also a lot of different signs of the disease, what we call minor signs, which are, for example, the skin, the hematomas, or the joint hyperexcity, and also major signs or complications, especially at the artery and colonic level. The fact is that this syndrome usually is unapparent until the age of 15 or 20, usually when first complication occur, and which makes all the gravity of this syndrome. The two main complications that we are seeing are mainly the arterial complication, and you see on this CTA an artery, a renal artery, which is aneurysm, with an aneurysm there, and you see also other type of lesions of the mesenteric arteries here, or the iliac artery there. The fact that this aneurysm can occur relatively young, in a young age, have the risk of rupture, and this is why it's very important to manage very carefully this disease. All the other minor diagnosis criteria are important to make the diagnosis itself, but are not so important in terms of prognosis, even though pneumothorax, for example, can be dramatic sometimes. So the second type of complication, which might be important or dramatic sometimes, is the risk of perforation of the colon, especially the sigmoid. And you see with this little arrow there that because of the defect in collagen, sometimes you have an intestine which is very thin and which is susceptible to perforate due to usually to constipation. The two types of treatment in that case are first a partial colectomy of the sigmoid to remove the entire colon and to make an ileorectal anastomosis with a total colectomy. So this is undoubtedly a severe complication. The three types of complication in terms of frequency are vascular in approximately 50, 60 or 70% of the case, digestive, which is approximately 15 or 20% of the case, and obstetrical because of the pregnancy and the possibility of especially rupture of the uterus during delivery, and also other complications during delivery. So all these complications are the major complications which can occur in the percentage that you are seeing on this slide. Because of that, when you are looking at the first age of the first major complication, both in males and females, approximately in 50% of the case, this first complication occurs before the age of 30 years, 25, 28, or 30 years, sometimes earlier, sometimes later, but on average as this. It's very important to be recognized as such because it's a rare disease, and usually the GPs and the practitioners do not know this disease and do not recognize the risk, especially of the fragility of the tissue during surgery. You have on the left here the publication made 20 years ago of the life expectancy of VEDS population followed in USA by Peter Byers, and it's approximately on more than 500 patients and affected and relatives. And you see that compared to the US population there, the life expectancy is much lower. And it was said at that time that on average, because of this possibility of early complication, even though some people can live much longer, the average age in terms of life expectancy would be 50, 55 years of age. We do not have, on the right of the panel, we do not have at all this kind of statistics since our surveillance of French cohorts, more than 15 years experience. You see the French survival there, usually. And you have on this trade there, the VEDS population. And you see that, yes, it's lower than the usual population, but not at that point of what we observed 20 years before. So that said that probably because of the lot of preventive measures and care which is given by a referral center, you might improve very strongly the prognosis of the disease. Coming back to the genetic defect, it's very important to understand what kind of mutation you might have. As you can see, the collagen there can be drawn as a peptide, which recognize mainly on the triple helix, which is made of almost 15,000 residues. And this triple helix can be mutated, especially on residues that are called glycine. This glycine is very important to make the arrangement of this triple helix and as homotrimer. And if you have a change of a glycine for another residue, then it will change the conformation of this homotrimer and make it more fragile and less efficient. So this is called dominant negative mutation. And this mutation affecting glycine residues are approximately 60% of the case in VEDS. In approximately 25% of the case, you have a splicing site mutation, which says that you have part of the residues which are disappearing, which are lacking, and which have a consequence also of a change in the conformation of the protein. And in approximately 7 or 10% of the case, what we call the null mutation, that are truncating mutation, you have just only one chain of collagen which is perfectly normal, and the other one which is not expressed because we have one copy from the father or the mother which is okay, and the other one which is affected by this mutation. And this null mutation, as we will see, have a relatively better prognosis. What you have to know also is that approximately in 50% of the case, when you have a VEDS patient, neither of the parents are bearing a mutation. So this mutation appears de novo, which is not transmitted by the father or the mother. And this experience is this one in our cohort of approximately 200 people, and this is exactly the same at the international level. So approximately half of the VEDS patients have no parent bearing the mutation. In 2 to 3%, it might be mosaicism. It is part of the cells of the parents part of the gametes are bearing this mutation, but it's very rare, so it's probably not useful to know that every day. But the 50% de novo is very important, obviously, for the genetic counseling. What is important also is to know that you have a very strong heterogeneity in terms of presentation and variability in the severity of the phenotype. On the left, for example, you have the percentage of patients with the first complication, and you see that on average, at the age of 30, 50% of the patients have had a complication. You see that the index cases, because they are coming for that, have a rate of complication which is higher than their relatives. So if you have usually a family with 2 or 3 brothers and sisters affected with the disease, often the one that you are seeing the first in the hospital is the more severe, and the other ones might be less severe. The thing which is interesting also is that from generation to generation, you might have the first generation which is more severe than the second generation, or vice versa. For example, in this cartoon there, you see that the index case, a woman had a colonic perforation at the age of 23, and she had already arterial lesions at the carotid and abdominal level in the mesenteric arteries, and she had also minor signs of the disease. And she was first to be diagnosed in that family. And when we came back to the family, it was very interesting or surprising to see that her brother, the next year after that, had a colonic perforation, but had already a pneumothorax several years before, had already some aneurysm in splenic artery and minor signs. And the disease was transmitted by the father, who had very, very mild disease, even though he had exactly the same mutation, of course, with only silent aneurysmal lesions and some varicose veins. So saying that within a family, you can resemble yourself for some of minor or major signs, but you cannot sometimes have the same complication. It's very important for the genetic counseling because sometimes you have families which are very severely affected with one or another person. And it's important to inform the family that even though you might have the same genetic defect, it's not mandatory that you will have exactly the same kind of complication. The things to know also is that the phenotypes, which are either minor or major sign of disease, are different according to the type of mutation that you might have. The dominant negative mutation, which are the glycine, the splice mutation, here in purple or in green, are the more severe. You see that the age of occurrence of the first complication is approximately 20-25. And if you compare that to the one with haploinsufficiency here in blue, you see that you have approximately 20 years of difference in terms of age of the first complication. So that says that definitively to have an homotrimer which is affected by truncating mutation or splice mutation, excuse me, or essence mutation on a glycine, it's much severe than to have 50% of your collagen, which is okay, collagen type 3. One thing also which is interesting to know is that the rarity of the disease is probably not very well established. For the moment, it's said that VEDS is approximately 1 over 100,000 individuals in one particular country like USA or France. And that would say that in France, we would have approximately 500 to 1,000 cases. And in USA, you'd have approximately 2,000 to 5,000 cases. Actually, when we are looking back now to the database which are available due to the genomic sequencing done in the usual populations or different type of population, we are surprised to see that you might have more a frequency which is higher of mutation than expected, and especially for the mild mutation corresponding to the haploinsufficient mutation or the null mutation, which appear to be about approximately 30% of the case in this database. That would say that we have probably a lot of undiagnosed VDS, and that it would be probably important to test frequently the people according to a minor or major sign of the disease or major complication. I'm coming back now to the therapeutic part, and especially explaining what can be done in terms of medical treatment for the arterial complication. One thing that we saw more than 10 years ago is that by an echo tracking, which is a very precise assessment of the arterial wall, especially at the carotid level, when you are looking at the VDS patient, the intima media thickness of the artery is much lower than the usual population with the same age and sex. And this is important because not only you have thin arteries, but because you have thin arteries which are more rigid, the risk of rupture is increased because you have this wall stress and can calculate there, which is increased by approximately 50%. So an increase in circumferential wall stress, which might increase the risk of arterial rupture. So it's important to know that because it's one of the bases of any treatment. You try to lower this wall stress, and by trying so, usually you're trying to decrease the stress in blood pressure, and by decreasing blood pressure itself, even though people have usually a perfect normal blood pressure. In terms of biological pathways, the mechanism which have been involved or discussed, and this is a very brief argumentary on that, based on the collagen itself and the decrease of normal collagen synthesis or increased collagen degradation. So this deficit in procollagen type 3 and collagen type 1 in terms of heterodimer, which collagen type 3, can cause in the arteries an hypertrophic remodeling and then a decrease in the wall thickness, as I showed before, and then a fragility of these arteries and a fatigue of these arteries, and the risk of dissection and rupture. And obviously, as I said before, the blood pressure in terms of wall stress and the pulsatil stress in terms of heart rate can be two triggers of dissection of rupture. That is why in our center, almost 15 years ago now, we launched a protocol called VEDS. It was an open randomized trial testing the effect of celiprolol, which is a beta blocker, a particular beta blocker, beta 1 beta blocker and beta 2 agonist, because of some arguments in terms of pharmacology, and to see if it could decrease at least the risk of cardiovascular events. And you have, this was done in different centers. It was randomized, open label, and it was conducted in 8 centers in France and 1 in Belgium. And you have an enrollment criteria. At that time, it was not mandatory to have the molecular diagnosis, and it was made on the criteria of Villefranche in terms of major and minor criteria. So it was randomized celiprolol, 200 to 400 milligrams versus no treatment, no beta blocker therapy. So the main results of the VEDS trial in terms of primary and secondary endpoints on the relatively numbers of 53 patients is that you had a decrease in events. For those taking celiprolol, you see that we recorded 6 events on 5 years follow-up compared to 17 events in control patients. You had all the number of patients at risk and number of events which are at the bottom of the slide, and with an hazard ratio of 0.3 and a very significant effect, even though it was a low number of patients. When retrospectively we genotype part of the patient because we couldn't find everyone, on the 33 which were molecularly proven VEDS patients, the tendency was exactly the same, with a better survival on celiprolol compared to those with no celiprolol at all. So this was said that it was interesting because for this rare disease for which we have for the moment no other randomized open label trial, this was the first to be tested and to show a favorable effect and a safe and good tolerance at a dose of 200 to 400 milligrams per day. Obviously, the fact that it was not a randomized double-blind trial and the number of patients limited and the premature termination also by an independent committee, and the fact that we use celiprolol compared to another type of beta blocker, celiprolol being not sold in other countries like USA, for example, made some discussion about the generalizability of this treatment. We have conducted more recently a long-term observational study in our center. So it was more than 140 patients, all molecularly proven, in just one center in Paris. It's mainly a retrospective study on more than 10 years. All patients usually are coming to our center and then have an evaluation, a clinical and radiological workup, and then are proposed to be treated or not by celiprolol at a dose of increasing dose of 100, 200, and then 400 milligrams per day. At each period, every 6 months approximately, or every year, depending on the availability of the patient, we have not only a clinical evaluation, but also a duplex ultrasound of the arteries and the CTA or MRA for imaging the vessel and see if we do not, or if we have vascular complication. What we saw is summarized in this slide. The thing is, as I showed before, on average, we saw a better prognosis than expected. That is, the life expectancy of VEDS patients is better than we saw and we thought before 20 years ago. And probably this is the case because of the knowledge of the disease by the patient and the care that they have, usually by preventive measure or therapeutic, different type of therapeutic that they might have. The second thing that we saw also is that this prognosis is dependent on mutation. If you have the null mutation, which are in green there, the risk of rupture of arteries and the risk of colonic rupture, for example, or death is really low. And we did not record any deaths during this follow-up for this patient with haploinsufficient mutation, which is not the case for the splice site and the glycine mutation. Finally, what we saw also, and this has to be taken carefully, but which is very significant, for those who are taking the celiprolol, approximately 85 to 90% of the case, life expectancy was better than for those who were not treated. You have to remember that it was not randomized, so we propose a treatment to everyone unless there was some contraindication. So this observation is of interest, but cannot be a complete assertion of an efficacy of the treatment. But nevertheless, the fact that it's a much better prognosis on treatment than without treatment is relatively encouraging, I would say, for treating the patient with this treatment. Especially when we see after that, when we post-hoc analysis, we are looking at those who are 400 milligrams compared to 200 milligrams, or who are non-treated at all. Those who were dealing with the complete dose of celiprolol were doing very, very well. During this observational study for years, you have the years 2000 there, and 2015 and 16. You see the number of patients in blue that we are following, more and more patients every year. And you see also the rate of hospitalization in red, and in blue, the rate of hospitalization with symptomatic arterial events. The thing which is of interest is it seems that in terms of hospitalization, especially for hospitalization with acute arterial event, you have a plateau starting approximately 2011, which is corresponding to the year when we began to treat everyone with celiprolol. Once again, it's not a definitive proof that celiprolol is a treatment, the elective treatment of VEDS, but it's a strong argument to show that it's relatively beneficial in patients. And I will end my talk by a general assessment with 6 different things that I would like to say. First, for me, it's important to discuss in VEDS, especially if you have already one case of VEDS in the family, an early diagnosis of the children. Should we diagnose at the age of 10, 15, earlier than that? It's always a matter of discussion with the families, knowing that usually the first major complications are not occurring before the age of 15 years, approximately. You have to understand that it's very important to have a precise molecular assessment of this diagnosis, since first, the mutations are not equal from one to another one, as I showed, and you have more and more new molecular variants which are called of unknown significance. It's very important to go to a laboratory which is a referral center for that disease to say if the mutation is functional or not. And this is going to the point 2. Once you have an index case which is diagnosed, it's very important to be able to go to familial screening and genetic counseling. Familial screening to be able to treat, if necessary, relatives with the same kind of genetic defects. And genetic counseling in terms of birth, and as to see if the parents, if one of them is affected once or not, to have, and in each condition, to have a child or children with the same genetic defect. Obviously, we didn't care before of the social follow-up of these patients, but we were surprised that a part of them, 10 to 30% of them, because of fatigue, because of different symptoms, have consequence on their work, on their familial life, and the psychosocial follow-up is very important, I think, for this disease, because patients have this disease all their life and possible complications all their life. obviously this is of importance to be followed up and treated, especially in case of depression or other things like that. The fact that you know the disease is important also to have preventive measures in terms of physical measures, not exposing yourself as a VEDS patient to trauma, for example, or to know by a card that you are bearing a genetic defect in collagen type 3. So in case of surgery, the surgeon can know your fragility in terms of tissue and make the things appropriate for that. And we see also for the treatment of major complication in case of perforation of colon, for example, or treatment of arteries, which are so pregnancy management is very important also. And we recommend C-section 2 or 3 weeks before the term to avoid the risk of uterine rupture and also perineal complication. And you have all these discussions about the good model and the good treatment for the long-term medical therapy. We have in France this policy to treat patients with celiprolol. I know that there are other policies in UK or Europe or in USA using not only beta blockers but also angiotensin receptor blockers, which might be also a good drug. We are finalizing a double-blind trial on that, but we have no proof yet that these different treatments are efficient. So my final word would be it's important for the patients and families to have a referral center to be able to ask questions on anything that they might have, either on the day-to-day life or complication. And so to my view, it's one of the things that increase very much their life expectancy and their life in general. This is it for me.
Thank you, everyone. Thank you, Dr. Jeunemaitre. We will be proceeding to watch Dr. Shaine Morris's presentation next, which is a little shorter, so we will have time for Q&A. I do see a couple of hands raised. If you could put your questions into the Q&A box, we will have a little bit of time at the end to answer questions. Thank you.
Thank you.
Hello, thank you to the VEDS movement and the Marfan Foundation and Vascular for the opportunity to present. I'm really excited to be part of the first International E3 Summit, and as always, I'm really excited to talk about vascular EDS, and I'm excited for people to have an opportunity to get more information as always. I'm a pediatric cardiologist and I work at Texas Children's Hospital, and a lot of my focus is taking care of children who are affected with vascular Ehlers-Danlos syndrome, or VEDS. So I'm just going to briefly talk about emergencies as an addition to the prior talk. All right, so the main emergencies I'm going to discuss briefly are arterial dissection or rupture of a blood vessel, aortic dissection, arterial rupture, carotid cavernous fistula, pneumothorax, intestinal ruptures, which are typically in the colon, and other organ ruptures, which tend to be liver, spleen, bladder, or gallbladder. So let's first talk, before I go into detail about each of the emergencies, I want to make sure everyone is really clear about the difference between an aneurysm versus a dissection versus a rupture. Now, I know this is being discussed in other talks, but just in case you haven't seen those, I'm going to go over it briefly. So an aneurysm is basically a dilation of a blood vessel. So if you look on the left of the screen, this is our entire arterial system, and the arteries are what is commonly affected in VEDS. And so what can happen in an aneurysm is that part of the vessel can get stretched out or ballooned out or dilated. This is an example of an aneurysm of the aorta. We call this the thoracic aorta Or this is an example of aneurysms in the iliac arteries, which are down here, right down past the belly button going to the legs. Now, aneurysms technically are not an emergency. They're a dilated area that's at risk of tearing, dissecting, or having a rupture. But they don't have pain typically, and they don't cause any symptoms at all. So you usually don't know that they're there, but we worry when we see them because we know those walls are thinned and at higher risk of a dissection or a rupture. So this is from a paper with vascular EDS. These are all the places in the arterial system that patients with vascular EDS can have aneurysms. Now, people do not have aneurysms in all these places at once. It's common to have one or two or maybe a few more, but these are all the places it can happen, all the way up in the neck, in the brain, down in the legs, but most commonly they're in the chest and abdomen. So let's talk about a dissection. So a dissection is different. The arterial walls have 3 layers here, 1, 2, 3. And what a dissection is when 1 or 2 layers has a tear and blood from the lumen or the middle of the vessel bleeds into the wall. And that creates here this what's called a false lumen. So it's a second, you see sort of a double barrel. The blood is going this way and more blood is going out this way. But this blood is going slow flow and can sort of clot and you get a double barrel. This is called a dissection. So it creates, like I said, 2 passages, the false lumen and the newly created pathway. This can be treated with surgery, but it's very important to know because it can progress and can cause compression of one of these vessels. And a dissection can also happen in the smaller vessels. These are examples of a neck vessel, carotid dissection, and you can see the bleeding is kind of causing this vessel to compress the open lumen of the artery, so it can block blood flow to the brain or wherever the small artery is going. You can see it here again. This blood, this slow flow tends to clot, and so that actual flowing blood has a harder time getting around. So there's also arterial rupture, and this is when the vessel breaks through all 3 walls and the blood can actually leave the aorta or the artery. And so this, if it happens in the aorta, the blood can go into the lung space, into the pleural space. If it happens in the abdomen, the pelvis, it can have frank bleeding into that space or into the renal arteries. It can bleed into the kidneys, etc. So this is really important, and this is the most life-threatening complication because this is arterial blood that's high pressure and can need emergent surgery. So what are presenting signs of an arterial dissection? Like I mentioned, aneurysms don't really have signs typically, they're asymptomatic, but dissections certainly do. So if we look at this arterial tree, depending where the dissection is, symptoms can be different. So if the dissection is in the head or neck, which tend to be the vertebral arteries, the carotid arteries, and the cerebral arteries, presentation signs often include neck pain or stroke-like symptoms, including weakness somewhere in the face or arms or legs, vision problems, or slurred speech. And this is from, like I showed you in the carotid artery dissection, some of the blood flow can get blocked, and so you have low flow to the brain, so it is basically causing a stroke, or sometimes it can cause temporary symptoms like a transient ischemic attack. Now, it's very rare to have coronary artery dissections, but it can happen in vascular EDS, and the coronary arteries are the small arteries that actually feed the heart. And when there's a dissection there, there's lack of blood flow to the heart, so this presents like a heart attack. It can, just like a typical heart attack you've learned about. So you can have chest pain radiating to the arm, pressing, it doesn't go away in a few minutes. Now, when I talk about this, chest pain is really common. I'm a pediatrician, and I think every patient I have has had chest pain at some point, but this is a crushing chest pain. It doesn't go away. It lasts for a long time. It's really different than like a chest pain that lasts for 5 seconds and goes away. That would not be a coronary artery dissection. So another common place is in the abdominal arteries or the pelvic arteries. So these are the mesenteric, the arteries that feed the intestines, the artery that feed the kidneys, the arteries that feed the ovaries. These tend to present when they dissect with abdominal pain, or if it's a really posterior artery, can present with back or flank pain. For example, the dissection to the kidney, those are really far back, that presents more like back pain. And the iliac arteries is a common spot. These are these arteries here that start under the belly button and go to the legs. Dissections here also tend to present with abdominal or pelvic pain, occasionally flank pain. And if there's blockage of that blood vessel to the legs, there can be weak pulses or difficulty walking. Now, what if one of these ruptures? Now, the presentation signs can be the same. However, if it's a rupture, you're having a rapid bleed out of an artery. So it tends to be worsening pain, more rapidly rapidly progressive symptoms. You can also have dizziness or passing out because of low blood, because the blood is bleeding into the chest or the abdomen or the pelvis. The patient can look quite pale. Another way it might present, especially for the small arteries, is if there's a large hematoma. Now, a hematoma is a blood collection that forms under a muscle or under skin. And I'm sure anyone with vascular EDS has seen these, but they're very large sort of bruises, but they're quite large. But if there's an artery that's torn causing that, it can continue to get larger and larger and larger. And if you're losing blood, it can cause dizziness or even passing out, and it's important to get attention. Now, what do we do to treat arterial dissections and ruptures? So for dissections, if they're in a small vessel, often we actually just medically manage them. We can give anticoagulation, that's blood thinner. We can give blood pressure medicine. We can follow serially to make sure it's not progressive. We really don't want to intervene if we don't have to. Now, if it is blocking blood flow to an important organ or that's not healing off, we might have to place a stent, which is sort of a cylindrical cage to prop open that wall so it's not blocked, or bypass surgery. And that's when you let the blood go via a different route through surgically putting in a different graft. Now, if there's a rupture, usually they need either stenting or embolization or an open repair of the vessel. Now, the problem is usually ruptures are emergent, so you're doing urgent surgeries, and these interventions can be complicated by further damage. So these are certainly the most threatening, especially if it's a large or medium-sized artery. Now, specifically talking about aortic dissection, I was mostly focusing on arterial dissections. The aorta is the largest artery of the heart, and aortic dissections tend to be grouped in two categories. We talk about type A dissections. Those are DeBakey type A or Stanford 1 and 2. This is where a tear starts on the top part of the aorta. The heart connects right here. This is the aortic valve. These start up at the top. Type B dissections have the descending aorta is dissecting, and we treat them differently. It's the reason I talk about them differently. So for dissection symptoms, they typically present with chest pain or back pain. It's usually continued, usually severe, usually tearing. Again, this is not the 5 seconds and I'm better, I was watching TV and I got brief chest pain. That is not what a dissection feels like typically. Usually severe tearing, although some people have mild symptoms, but that's the rarity. Shortness of breath can certainly occur. If those tears are blocking blood flow to the legs, they can have leg pain, difficulty walking. If the blood flow is being blocked to the brain or to the neck vessels, there can be stroke-like symptoms, blurry vision, weakness, and slurring. And if there's a rupture, there can also often be severe pain and loss of consciousness. So what do we do to treat aortic dissections? For type A, usually emergent cardiac surgery is needed. And what we do is we replace the aorta with a graft. This is a synthetic material. We take out the part that's torn and replace it. For a type B dissection, which is sort of one of these, we actually often medically manage it. The surgical repairs are quite complicated and sometimes cause more harm than good. So if it looks like the patient is gonna make it okay, we will give blood pressure medicines. We'll possibly give blood thinners, and we try to let this heal on its own. If not, though, like you can see here, this illustrated dissection is causing sort of some compression of this iliac artery. We might have to put in stenting or do surgery. Now, I just mentioned that if blocking blood vessel to vital organs might need to intervene. Now, another complication that can happen with VEDS is something called a carotid cavernous fistula. This is an illustration of the vessels and bones of the face. Here's the globe or the eyeball. The carotid artery, which is one of the arteries, main arteries that comes off the neck, has a couple of little bends and comes up right behind the eyeball. And there's a venous drainage pocket right behind it. This is arterial. So this is high pressure, this is low pressure. And you can actually have a rupture, a spontaneous or with trauma rupture that allows this blood to go in here. This is really high pressure blood and go to low pressure blood. And this can cause a lot of pressure on the eye and eye socket. And so this is called a carotid cavernous fistula. Symptoms of this can be pain behind the eyes, blurry vision, a bulging red eye, weak eye movements, or tinnitus, which is the ringing of the ears or a swishing. You can actually hear because this is really close to the ear canal. And usually the treatment for this is embolization. And what they do is they take a little device, a coil or a plug, and take it with a catheter and plug up this spot to stop the bleeding into the cavernous sinus. Pneumothorax is a collapsed lung. This is an illustration. This is an actual picture. If you can see here, I know it might be hard to see if you're not used to looking at x-rays, but normally the lung looks kind of light gray, and you see all these little blood vessels coming out. This is the heart in the middle. This is the spine. But if you look on this side, there's a lot of blackness out in the lung area, and that's because this is the actual lung, and it's collapsed, it's shrunk in, and there's really nothing out here except air. And this can happen in vascular EDS. The treatment for this, the symptoms are shortness of breath, a low oxygen saturation, and chest pain. You don't have to have a low oxygen saturation, but that's common if it's a large collapse. The treatment, if it's a small pneumothorax, is usually just giving oxygen and observing overnight. If there's a large pneumothorax like this one I showed here, we actually do something called the chest tube, where we take a small plastic tube and a surgeon will insert it between the ribs to decompress and get that air out and seal it, and so that the air doesn't keep leaking into the lung field. Intestinal rupture is also commonly seen in vascular EDS. The signs and symptoms are typically acute or rapid abdominal pain, progressive. The pain tends to get worse. The abdomen gets tender to touch. People have no appetite. Constipation might be involved. We think that constipation is common in vascular EDS, and sometimes people get stool impaction or chronic narrowing or inflammation of the intestines, and we think this adds to it. So it's a common thing to see intestinal inflammation or constipation at the same time as a perforation. This is a CAT scan. This is the spine of someone laying up. And what this is pointing out is little air pockets there and some edema, some swelling that we don't typically see in the intestines, but this is because someone has had an intestinal perforation. This is just an illustration of something similar. And the treatment for this is usually to repair or to resect the part that was affected or torn. Now, patients with VEDS can have rupture of other organs. There's a long list, but some of these include the liver, the gallbladder, the spleen, the bladder. And depending where it is, controls the symptoms, but usually it's significant pain, abdominal pain, or back pain. These are often triggered by trauma. It's less likely to have a spontaneous liver rupture or rupture of one of these organs. Intestinal rupture certainly can be spontaneous. These are less likely to be spontaneous, but they might be caused by minimal trauma or by major trauma, like a car accident or a bike accident. This is an example. This is an image of a CAT scan again. Here's the spine. Here's the stomach. We're looking up. This large thing here is the liver, and this is a bleed into the liver. It should all look kind of like this white, similar material, but this is blood coming into the liver. And treatment is usually surgery to repair the area of tear or to remove part of the area that has bled, depending on where the lesion is, but these are quite important. So this is, I know this is small print, this is just for reference if you want to go back and review. These are all the emergencies we talked about. These are the presenting features, and these are the most common treatments. Of course, you have to work with your healthcare team to decide what's right, but just so you recognize the common emergency presentations. And so basically, in summary, vascular and intestinal injuries are the most common emergencies. Most are addressable if help is sought soon. And the really important thing is to seek assistance quickly. You'll have to educate your provider as much as possible regarding increased risk in VEDS, or work with a team that knows. And if there's time, seeking input of experts. And that might be calling people, finding people in the hospital that are aware, just to make sure that all caution is taken to make sure the right diagnosis is made and the right care is given. So I appreciated the opportunity. This is just a picture of our hospital and our genetics team at Texas Children's. I look forward to hearing some questions. Thank you so much.
Thank you very much for those presentations. Dr. Morris and Dr. Jeunemaitre, if you'd like to turn on your video for the Q&A portion, I think that would be great. And we will move right on into the Q&A. I know we've received a lot of questions, but I would like to start with one for Shaine, because we did hear a lot about celiprolol today, the beta blocker. And could you briefly summarize how VEDS is treated in the United States and what the thoughts are here with the recent FDA denial of celiprolol?
Sure. Yeah, I'm happy to talk about it. It's a little controversial, and I think there's kind of three schools of thought in the U.S. I think one of the big concerns is while it's amazing that a trial was done in rare disease, I think there were some weaknesses of the trial, and now that everyone's on it, it's really hard to compare, taking into account both ERA effects and controls of the meds. So I think while the data is super interesting, I think not everyone is totally convinced, and that is manifest by a few different treatment patterns in the US. So there's some of us, and that tends to be more the southern US, that do think there's potential for a beta blocker, but it's not clear that it has to be celiprolol. So a lot of us will prescribe a different beta blocker, and often in the 3rd generation class that might have similar effects. There's also the thought that maybe most of this is blood pressure mediated and just putting on a very good blood pressure. So along the eastern coast, a lot of times either a beta blocker or losartan is used. And if you know people treated in the Hopkins area, there's a lot of familiarity with losartan, and that's commonly prescribed. And in the Northwest, there's a little more doubt about the studies and the effectiveness and thought about side effects. And so I think there's a mixture of people who have had events are commonly treated, but people without events commonly are not put on medication. And I think in general, we just want some more data about other beta blockers and clearly about placebo in patients who have not had an event. So.
Thank you very much for reviewing that. I know there are differences between here and where Dr. Jeunemaitre is, and I really appreciate both of you sharing your perspectives on that. So maybe this is for Dr. Jeunemaitre. We had a couple people upvote this in the group. Can somebody with VEDS be an organ donor after they die, or is there a problem with the tissue not being strong enough to be an organ donor?
Well, I think it's probably a good question, though it's probably rare, but to my view, VEDS patients are not good donors since the fragility of tissue is probably not recommended for long time after that recovery of the tissue and for the people who will get the corresponding organs. So I would not recommend that for a transplant.
Thank you. For our next question, maybe Dr. Morris, you could answer this one. Maybe I'll just switch back and forth between you. What Marfan characteristics overlap with VEDS, and are there enough similarities that might result in misdiagnosis?
I think if you're going to a clinic pretty familiar with these, you know, it's pretty easy to tell the difference, but there are some overlapping characteristics. Some people with Marfan syndrome have joint hypermobility, and in VEDS, you can certainly have joint hypermobility. It's not everyone. Flat feet is common in both. Sometimes people with Marfan syndrome have soft skin, but really it has more overlap with Loeys-Dietz syndrome than with Marfan syndrome. You know, the really tall stature that you see in Marfan syndrome is you do not see in vascular EDS, and same with the facial features. And those features are a lot more subtle in Loeys-Dietz. So I think it's a lot easier to confuse it with Loeys-Dietz syndrome. I think in rare circumstances, possibly with Marfan, but not a ton of overlap.
Thank you.
Yeah, totally agree with Shaine. I think that's Marfan and VEDS are relatively dissimilar, though, as you said, you have some cases of Loeys-Dietz which are rare too, but which might be more similar to VEDS than the others. The good thing now is that actually due to the genetic screening that takes usually a series of genes implicated in the kind of disease, you can tell the difference using this genetic test.
Yep, and every gene panel now has Marfan and Loeys-Dietz and VEDS all in the same panel.
Absolutely.
So. Great. So for Dr. Jeunemaitre, so we have a question about kidney infarction and VEDS, and I think we did talk a little bit about this as far as the dissections that can occur. Is kidney infarction common in VEDS, and can it result in a future emergency situation? What type of doctor would be the right doctor to monitor this situation?
I do not have a perfect percentage, but I can tell you that the percentage of renal lesions among the vascular lesions that we have in VEDS is approximately 20%, I think, approximately. But you might have small aneurysms or dissection is more rare. But it's not uncommon to have as a major complication dissection of the renal artery with a back pain, which is important, with hematuria and an infarct renal, which is an increased blood pressure. And this is problematic since because you have this blood pressure, which is increased by the ischemia of the kidney, you will have even more risk of dissecting other kind of arteries. So it must be very carefully taken in charge. And during not only the acute phase, but during the months after that, to be sure that you have not only the artery which is recovering, but the tissue itself. So it's a matter of specialists. You might have a medical treatment, you might have endovascular treatment, you might have surgery. It's really dependent of the renal lesion itself, but it might be Shaine has some experience on it.
I totally agree with you. I mean, we just have to be, I've certainly had patients that have had a renal, or patients' parents who've had renal artery dissections and infarcts. So it's certainly a possibility. And same as you said, we have to be very careful because the renal artery has a hormonal system attached to it that controls our blood pressure. And so when that's altered, it can certainly increase your blood pressure. And that's a major challenge.
It's probably a very good indication to the Zartan, so the angiotensin type 2 blockers, because the increase of angio2 when you have a renal infarct or ischemia.
Okay. So this one is for Shaine. I know that you work with children. So for a 6-year-old with VEDS who has a bad temper, how dangerous is this, and what, if any, recommendations do you have for anger management?
Well, sure. Well, kids overall with VEDS, most of them do very, very well. I follow lots of kids. If you just look at kids, unfortunately, it's a higher risk group because they've been diagnosed. So if you take a group of kids like mine, I have a higher risk that have had events than if you look at a large group like Dr. Jeunemaitre showed. But most kids do really well. I mean, spontaneous events are pretty uncommon. And if if they get upset, that's fine. Now, if they're having self-injurious behavior when they get upset then that's a challenge, but that's a challenge for any child. So if they're injuring themselves when they're mad, something like behavioral therapy might help to learn ways to control that anger. If it's just they're getting angry because they don't get what they want, it's okay to let them be angry. It's okay to let them cry. It's okay to get them mad. They're not going to rupture a blood vessel from doing that. And that's part of normal, setting limits is part of normal child rearing. And we do see a challenge, and I take care of kids with chronic congenital heart disease, as well as these connective tissue diseases. And I think kids parents are really worried about disciplining like they normally do. I mean, obviously there shouldn't be any hitting, but in terms of disciplining and setting limits, and it's okay to do that. We have a lot of people who that's hard for. So to just treat them like your other kids in terms of setting limits too.
Thank you. And I mean, we do have a lot of questions, and we're right at the end. Would you both mind staying an extra 5 or 10 minutes to answer a couple more questions?
Yep.
Okay, great. Thank you. So our next question, and maybe this is different between France and the US, so I think maybe Dr. Morris can answer first, and then Dr. Jeunemaitre, you can answer after. Who is supposed to be coordinating the care for somebody with VEDS? Is it a cardiologist or a PCP or somebody else?
Well, I think here in the US, I'm going to give a couple of answers. So in general, for adults, it's different than kids. So in adults, it depends on who's going to take ownership. A lot of times I think that is a vascular surgeon or a geneticist, but it sort of depends on who knows the disease and who's willing to do it in your area. In kids, it's almost always a pediatric cardiologist. Vascular surgeons are not trained in pediatrics. It doesn't exist. I work in the largest children's hospital in the country, and we contract with a vascular surgeon. We just don't have a need for vascular surgeons. And so it's almost universally a pediatric cardiologist for children. But once you get to adults, you're routinely seeing some people are routinely seeing a vascular surgeon or a geneticist, or sometimes a cardiologist, especially if you're following a vascular trained cardiologist. So I think it could be any of those, and really it should be the person who's familiar and willing to take it on, because you kind of become a secondary PCP. And so you just want to find someone who's willing to do that for you.
And Dr. Jeunemaitre?
Well, in France, we have a particular organization since actually for rare diseases in general, there has been incentive for more than 10 years to create referral centers. So people know with this rare disease that in cities, you have one given center which is specialized for that. So in this referral center, usually you have the aggregation of not only a geneticist, but a vascular medicine person, also cardiologist or nephrologist if necessary. So I would say that as Shaine, probably a person dedicated to vascular medicine, vascular surgeon is probably welcome as the leader of it, in addition to a geneticist because of the many complications. But obviously, you have a lot of things, I said, and as Shaine said, on this syndrome. It's very important to have different specialists around a given family.
That leads right into our next question, I think. Establishing a team for a 10-year-old child with VEDS, or maybe anybody with VEDS this would apply to. Do you recommend aligning with an out-of-area VEDS specialist or a more locally available resource, or both?
I'll comment since I see a lot of kids. I would do both. So I think it's really important to have a local champion who knows you, who knows how the hospitals work, who knows where the best place is to go to get certain procedures or certain advice, or who the best specialists are in your area. So that's really, really important. But I think if they're not someone who sees VEDS or has seen, I mean, most pediatricians never see VEDS, and even pediatric cardiologists might have one or two, and even geneticists, the same thing. So I think aligning with someone who is pretty knowledgeable remotely. And so like I see people from all over the South, and so they can call me anytime if there's questions, the providers or the patients. And I know people in the VEDS community here in the US, a lot of people do that, so they can reach out at one time. And I think having both an expert and then your local team are important.
Thank you.
Same thing in France.
Same thing. Great. I think this is going to be maybe 2 more questions and then we'll call it a day. So for someone who has VEDS, who's known about their diagnosis, what do you recommend for people who are in their 20s or just really struggling with the diagnosis emotionally? What do you normally recommend for that?
Do you want to go ahead, Xavier?
We have a particular procedure in Paris where actually when we see the people or the relatives to a family, we see them with a psychiatrist or with a psychologist who's evaluating the importance of the psychological stress of the diagnosis. And we usually repeat this outpatient visit for every 6 months for sometimes 2 or 3 times, but 4 times for years. So from one given individual to another one, the consequences in terms of psychology are quite different. And it might be also different along the life. So I think it's important, yes, to have this possibility to see a specialist and to adapt the treatment if necessary.
And I agree. I mean, I think getting treatment, and that can be a lot of things. It can be finding help from your community. So for some people, that's coping through your like church or family. Finding a therapist, I think, can be critically important. I feel like in children, that's one of the most effective options. And then there's medical therapy, of course, if necessary, and working with a therapist to do that if that's necessary. It's not contraindicated. In that.
Obviously, patient association might play a role important also, as you said.
Thank you. And I'm going to ask one last question. We've got quite a few here, so we will be following up with these or asking people to submit them to our help center. So for somebody, is it possible to have VEDS without having any vascular or organ injury by the time one is 40? Is that possible?
Yes.
Yes.
Absolutely.
Okay.
We are following approximately 200 families, and in approximately 10 to 15% of the cases, even 20% of the cases sometimes, we have adults more than 40 years of age without arterial symptoms. Very, very surprising, but we don't understand everything, obviously, but yes, this is not a fatality.
Yeah, and we have the funny position of doing a lot of reverse diagnosis. We'll diagnose a child, and then we'll do cascade screening and find out a parent has it. So we have a few of those families, and the parent hasn't had any symptoms. And we think, possibly there's modifier genes that are making their tissue less fragile, and so they've gotten by further. And especially in the families with haploinsufficient genes that have a more mild phenotype anyway. But definitely.
Great. Well, thank you both so much for your time today and for your time preparing these presentations in advance. If your question wasn't answered, please submit it to marfan.org/E3ask, and be aware that our help center is getting a lot of questions right now, so it may take a little longer to get back to you, but we will do our best to get back to you. And also complete the session survey in the Whova app. We'd really appreciate it. Have fun connecting with community in the Whova app. There's a lot of great resources, and we hope that you visit some of our other sessions as well. We have several more on VEDS, including a vascular surgery presentation tonight. If you want to share your experience on social media, please use our hashtag E3Summit20 to share your experience, and have a great day. Thank you very much again, Dr. Jeunemaitre and Dr. Morris, and we'll see you soon.
Thanks, guys.
Thank you. Thank you for this opportunity. Thank you.
Thank you.